This is Transparency, a podcast by Gender Dysphoria Alliance, hosted by Aaron Kimberly and Aaron Terrell. Each week we'll be joined by people who have personal or professional experience with gender dysphoria and physical transition. We'll also discuss how our trans experiences relate to the concept of gender identity. Join us for a compassionate yet heterodox approach to the question of trans. Jamie Reed is a self-described queer woman and mom of 5. She holds a Master's of Science in Clinical Research Management and previously worked as a case manager at the Washington University School of Medicine's Paediatric Transgender Center at St. Louis Children's Hospital. She left the position in November of 2022 due to growing concerns that they were harming rather than helping many of their patients. Last month, she published a story in the Free Press of what she described as morally and medically appalling clinical practices. Here is our conversation with whistleblower Jamie Reed. Thanks for joining us back at Transparency. I'm Aaron Terrell, joined as always by my co-host Aaron Kimberly, and today we are incredibly delighted to be joined by Jamie Reed. Thank you, Jamie.
Thank you for having me.
We've really been looking forward to having a conversation with you. Most of our listeners, Jamie, will kind of know you as the whistleblower is sort of the term that they are now known by, and will be written into history for. I'm sure it's been an adventure for you. But I think where we would like to start is sort of where you found yourself and felt a need that whistleblowing was a necessity. Now, I mean, you've outlined some of the details of what you've released in your Free Press article and the webinar you did for the Free Press, and then Jesse Singal's article. So we'll link those underneath so you don't feel like you have to necessarily rehash all of those details. But I would just love to hear about how you entered the work at the Gender Clinic, where you were at with your thinking with that, what your intention was at the time, and what were you starting to see that shifted your thinking?
Yeah, I think that's a great place to start. So I worked at the Pediatric Gender Center for roughly 4 years and about 4 months. I came to this work directly out of working with youth who are HIV positive. So I have a lot of experience and a lot of passion about working with adolescents and young people. So that's kind of the age group. I was finding in the HIV care that I was doing that I was kind of becoming the known caseworker who could also assist with things that our trans and gender diverse clients were needing. So assistance with name change, gender markers. I remember starting to talk to people about what employers were good to go work at if you were trans. I remember starting to write letters and helping people navigate asking the workplace for bathroom accommodations and which restroom they could use. So I really started working with the trans community a couple of years prior to going to work at the Gender Center. I came into working at the Gender Center when it was still WPATH SOC 7, so Standard of Care 7. And I was really familiar with that as a document and really felt like joining that center was going to be a really good lining up with my passions at the time. So I came in 2018, and my timeline there really lines up with this broader timeline for what is happening with the American Academy of Pediatrics, with WPATH and the Endocrine Society. So in 2017, the Endocrine Society put out their kind of standard of care, and that was in conjunction with WPATH. And then in 2017, the center opened at Children's Hospital. I remember finding a lot of camaraderie with my coworkers. I really miss a lot of my previous coworkers. We were a tight-knit team, and when we were all on board and all in agreement, it felt like kind of a workplace family. And it was hard as that started to shift and slowly erode and fall apart. I think one of the first real gut-wrenching moments when I started to question things was a meeting that occurred with our two co-directors, the nurse and myself. So we kind of had a biweekly meeting. We would go through the patient charts, the list, like run the list for what was coming up, and we would have some like larger policy kind of procedural conversations. And for some reason, there started to become this pretty serious conversation between the two co-directors where the adolescent medicine doctor was talking about the reason why we were doing this work is to treat gender dysphoria. Seems like what everybody thinks.
Yeah.
Why we're treating pediatric kids is we're treating a condition, and that condition at the time was referred to as gender dysphoria. The endocrinologist took a totally different stance, and he was basically saying that he doesn't care or doesn't need for a young person to have any gender dysphoria, doesn't care if they have any distress around it, doesn't care if it's causing these things. Basically, as long as the youth could say that the changes that they wanted with their body lined up with what the hormones could do, he was fine treating them. And somebody threw out the phrase then, well, then isn't this just cosmetic? Wait, why are we doing this to kids if you don't have to have a distressing condition that it, and the two of them kind of started debating whether or not then we were doing this for cosmetic reasons. And I walked away from that meeting going, okay, the leaders don't even agree with the basic fundamentals about what we're doing. Mm-hmm. And that felt almost pretty scary.
It kind of mirrors exactly what Hannah Barnes was describing in at the JID Center, the Tavistock, same exact thing, like two completely fundamentally different understandings of what is being treated. But in that case, it wasn't at the director level; it was just between the clinicians. But yeah, so you're saying top down, no idea what we're treating or no agreement. Yeah,
no agreement, and that I think was one of those moments where, okay, so I started thinking this through a little bit more. And then what slowly started happening was it's just the patients. It just came down to really the medical questions with the patients. So one of the big parts of my job was I completed all of the triage intake for everybody coming in, so the new patients. And before I kind of jump into that, I want to acknowledge that I think our center sees patients in potentially a different way. And I think that youth and pediatric centers across the country might do this differently. So I do know that some centers will basically schedule everybody. Everybody gets a first visit. And at that first visit, it's like an hour or two long. And the patient meets with the social worker, the psychologist, maybe the adolescent medicine doctor, and the endocrinologist. So I've heard of a model where everybody gets scheduled, everybody sees everybody, and then they kind of go from there. That's not what we were doing. I don't entirely know why we set it up the way we did, but instead I would do this hour-long, 30-minute sometimes phone call where I would basically do this whole triage and then have to make a determination at the end of it if an appointment was necessary, what kind of appointment was necessary, and who is this young person going to see. And at the very beginning, I had maybe 10 phone calls a month to do. And they were oftentimes younger kids, and they were oftentimes more natal boys. And somewhere about the 1.5 to 2-year point, it started going from 10 intake calls a month to 30, and then from 30 to 40. And then there were some months where I was close to 50. And the patients changed. The kids who were presenting changed. We got to the point where it was about a 70-30 split. So 70% were natal girls and 30% were natal boys. And also that the age changed. And so sometime in 2001, no, 2021. That was the wrong year. Sometime around 2021, 2022, when I started looking at these numbers, the age of the kids presenting would be natal girls, and they would be 15, 16, which also didn't entirely match up because the concept is supposed to be if you have childhood onset, it worsens at adolescence, and then care is sought. I mean, isn't that's kind of the concept. A 16-year-old natal girl has already been through puberty. Puberty didn't just start, it started 3, 4, I mean, they could have been menstruating since they were 11. And when I'm on the phone with these parents, they're telling me that their kid really had no childhood gender issues, and that they were oftentimes the kids had just come out 3, 4, 5, 6 months ago. And also, a lot of these kids were having these stages. So the parent would tell me, well, first they came out as pansexual or what, a whole list of other demisexual, pansexual, all this whole thing. Something about their sexual orientation first. Then it shifted into trans or demi boy or some kind of non-binary, gender queer terminology. And then it shifted into some sort of trans identification. And so some parents were also like kind of trying to follow along what was going on for their kid too, as this identity was not solidifying. It was very shifty and it was moving around a lot. So these are the kids that were really just starting to present to us in higher and higher numbers. And that to me was a red flag. And I think it sounds like I use the term red flag a lot, but there are a lot of red flags in what I was seeing. Ethically on intake, ethically on who was presenting, and then what was happening to them once they were being seen.
What direction were you getting? Because you said it was your job to sort of meet with them, collect that information, then decide if they're going to get another appointment and with who. So what was the direction you were given as far as your decision making around that, and who would qualify then for that appointment if their philosophy of care was more just anyone who wants it should get it?
So that's a really good question. And I think one of the problems with this care model, not just in the United States, but I think you're going to see this mirrored exactly in Tavistock JIDS. We were completely under-resourced. We were totally and completely not provided the resources and the staffing needed from the top-down level of the hospital. So there would be months at a time where I would be told, we don't have enough psychology service staff available. You cannot refer anyone to psychology. Okay, well, all of the parents who were calling thought that their kid was going to see a mental health provider. And I'm having to tell them on the phone, I have no mental health provider available. So there would be periods of time when I had no psychology available. You could only go to adolescent medicine if you were an adolescent. So I had an age criteria. Also, the adolescent medicine doctor, at the beginning, we were trying to reserve her for kids who maybe really were still questioning, maybe seeking menstrual suppression, weren't really, all gung-ho about hormones. That shifted. She decided she was wanting to prescribe hormones, which kind of left me with, I could really only send you to a hormone provider. Psychiatry services were so incredibly limited that the triage criteria I had was basically you had to have failed 3 or more mental health medications, had to have multiple suicide attempts, really severe mental health. But at the same time, on the flip side, you couldn't be that mentally ill that, the services that we had available were constantly shifting. And so it also kind of became what's the phrase? Russian roulette. If you're a parent and you called 1 month, I might have X available for you. But if you called 2 weeks later, I might not. And so your kid might end up, yeah, I can send you right to psychology and you can spend, a couple visits with the psychologist. Or it would be the only people I have to send you to is the endocrinologist. And that does not lead to a consistency in the type of care being provided either. And so most of the phone calls were parents desperately wanting their child to be seen and me basically saying, I can email you a list of therapists and everyone on that therapist list is going to be affirming. And I know that they're going to write a letter of support. And I know that they're going to basically green light a pathway to hormones. And then there were some parents who found out kind of through the call what we did. And they were like, oh, hell no, this is not what I wanted for my kid at all. Like, this is not what I thought I was being sent to. What are you like? I mean, I had parents straight up tell me on the phone, like, are you kidding me? You're telling me that you would schedule my 13-year-old with an endocrinologist, like right off the bat. And so then so basically I had half my job was just pissing off parents on the phone and trying to like manage this like very upset group of parents who rightfully deserve a much better response from the medical care establishment. There should be mental health services available for these kids.
Yeah, I think most parents are expecting a thorough assessment process and a diagnosis and some psychotherapy and make sure that the kid's really aware of what they're getting themselves into and that that's going to be stabled over time. And that doesn't seem to be happening in very many places these days. I mean, I was experiencing similar things to what you saw here in Canada as well. And, activists frame this as first they were saying this doesn't happen anywhere. And now that the Cass report, and I mean, it's been thoroughly investigated in the UK. Now activists have shifted and said, okay, well, it was happening in the UK, but it's not happening here. It's not happening in North America. But you're saying, well, it was happening at your clinic, and I'm saying it is happening in Canada. That was the direction I was being given by our health authority. Was people have a right to do whatever they want with their bodies, and so your role really is just to provide them some education, and like you said, as long as they have a reasonable understanding of I'm going to get these effects from this intervention, then they have the capacity to consent and you rubber stamp them through. So this model of care does seem to be pretty widespread.
I think it is. And even when I could put through someone to psychology, our psychologists and the way that they set it up was that they could provide the assessment for a letter of support, which is what we referred to as the piece of paper that said, yes, you can go on to blockers or cross-sex hormones. They would do that in 2 visits. And they straight up, that was not like sometimes if they're really clear cut, it's 2 visits. Oh, no. That's all that they were like, we schedule this in 2 visits. And when WPATH SOC 8 dropped, which does specify that that there should be a parent only or a parent like session also. I did kind of ask, I was like, does that mean that you're going to at least make it 3 visits? Because if you need 2 to meet with the kid only, are you going to meet with the parent for one of those? But to this day, I cannot wrap my head around how 2 visits is enough time to assess anyone. And I've worked in like social care for years, and it often took me 1 visit just to develop enough rapport with an adolescent or a young person to feel like we actually even were like on the same page about how we're going to talk to one another. I mean, it takes an hour just to get a teen or an adolescent to like be like, okay, I'll trust you enough to even like really tell you what's going on for me. How you could do the in-depth assessment and processes that need to happen for really understanding where a young person is to really even start discussing interventions like blockers and cross-sex. I think to be honest, you probably need 10 to 12 sessions.
Yeah,
if you really do the assessment.
And these kids are getting all their information from online or their peers, so aren't necessarily getting accurate information either. Where there's certain education that you were supposed to do with each of the clients you spoke to, or was that something that happened further downstream from you?
I think that's really a great question, because I was finding myself on the phone with parents. Often parents would say, well, my kid says that they want a puberty blocker. And I would say, okay, so you have a natal girl. When did they start menstruating? When did they start bleeding? And the parent would say, oh, well, it's when they were like 10 or 11. Like, okay, well, they're now 13 or 14. I'm like, by that point, the pubertal changes in the body have already occurred. And so then I'm asking the parent, did the child tell you why they were asking for a puberty blocker first? Do they even know that they've already, like, it was doing basics. I don't know if the phrase is right, but like sex ed, like human body biology. Like, I'm really concerned that these kids don't even have a firm understanding about where their own body is at. Like, hey, you're 14, you've been bleeding for 3 years. Guess what? You've already been through most of the puberty that's going to happen, where there's nothing else really to block here. So, like, why are we talking about a intervention that's the price of a new car that takes 9 months to get your insurance to I mean, like, all these things. And the parent was just kind of like, oh, okay, so what do they kind of qualify for? Um, but really the process was, if you were seeking medical transition and the parent was at least willing or wanting that appointment, we would schedule you with one visit with endocrinology. It was an hour long. And if you either had a letter of support already from a therapist who would have written you that letter in 2 visits, that was it. Then at the end of that visit, if you give us the letter, if the parent says yes, and you're willing to go get your labs drawn, you could get a prescription for testosterone. And so, I mean, in theory, we're talking about potentially in a 3-hour period of time.
It sounds like
in those assessments, was there anything that would kind of disqualify? It seemed like from obviously from the Free Press article that there wasn't really any disqualifying answers or behaviors, and you're not like were there things that the psychologists were looking for as like red flags, to go back to the buzzword, or
I thought I would have hoped that there would have been. But then when you read some of the letters of support, sometimes they would even document things like, it would say in the letter, young person expressed that they experienced sexual abuse or sexual trauma, doesn't want to talk about it, has had no trauma therapy. And you would think then the therapist at the end of their letter would say, at this point, this young person should probably go through trauma therapy and have therapy to resolve this. There were letters of support that even said things like the young person was describing that they had experienced sexual trauma, and that they were even to the therapist saying that they were really concerned about what would happen if they had genital growth with the testosterone. Yet the therapist was still saying at the conclusion of the letter that they were still a good candidate to start cross-sex hormones. And as long as the letter said that, again, and a parent was willing to consent, those were considered okay. They were considered meeting criteria. And then there were also the patients who had autism, who had shifting gender identities, that I these became the ethical dilemmas and debates within the team. And it was a small team. I mean, we had a team of maybe, I think if you count it up, maybe around 7 or 8 individuals. And we would sometimes discuss those cases. And, from my perspective, I would be saying, I don't understand how this person is a good candidate for this medical intervention. They are literally saying to the therapist, and it's documented in the letter, that they have concerns because of their sexual abuse history about genital growth. And yet we all know that testosterone is going to cause this. So how is this a good candidate? And I was always overruled. Always. There was one other staff member. We didn't always agree exactly, but would often agree with me in a similar fashion. And we were always overruled. And that is where my really deep-seated medical ethical problems sat. Because it seemed like no matter what was being raised on that multidisciplinary team, the answer was always cross-sex hormones were okay.
Did they provide any rationale for that? Like, what do you think their thinking was in cases like that?
So I think there's a couple problems here. And one of the problems is that there's really no, so what's the model to say no? So what do we do if we say no? We've already outlawed, quote, conversion therapy, right? I mean, so what, if you say no, you have to say no to the parent and the kid. And then you have to say, what is the alternative? Do we have a system set up as an alternative? Do I have a therapist available in my region that's actually going to be able to spend the year, the 2 years, the 3 years needed to really do the true time in therapy that young person needs? Because what happens then is if you say no, go to therapy, then you are potentially going right back to a mental health model that's going to hear a kid say gender and do what? They send them right. It's like nobody is willing to step up and say, okay, I'm willing to try to do the other model. And I am not in any way suggesting there's any sort of conversion therapy that needs to happen, but there has to be mental health providers who are willing to step forward and do the work, the slow down. Let's process this. Let's go through these things. And also then support the family, because the families need support when you have a young person who is demanding and wanting this intervention yesterday, and the conflict that it causes within the household. So there were so many cases where I would just be advocating, okay, can we tell them, no, go spend 6 months in trauma therapy, go spend 6 months in DBT, go spend 6 months in CBT, go spend the time in the therapeutic models. And then it became, well, do you have that therapist available? Even if they were willing to take on the gender kid, do I have the resources available to actually provide that? And I think that comes back to, no, as a society, we have completely been telling young people, honestly, on some level, we don't give a shit that you are in complete mental health crisis right now, because it doesn't exist.
Well, one of the things I was told was that people have a right to be both mentally ill and trans, just like someone has a right to be mentally ill and gay. And so you wouldn't gatekeep on the basis of a psychiatric condition or so the.
So are we talking about adults or kids?
Both.
Because that's where I feel like that's where my ethical line here is. I almost on some level completely agree. If you are an adult and you have the right to be mentally ill and trans, absolutely. And you have the right as an adult to As long as you can provide informed consent and a good consent model and as long as you have a firm understanding of what you are consenting to and are mentally clear enough to understand what you're consenting to, you're an adult, those are your decisions. We are talking about children. And no, I do not believe that as a society, we have reached a point where we are going to say to kids, we're going to not treat your mental health needs and medicalize you in a way that will permanently affect your body. I don't want to be in a society like that.
Mm-hmm. And I experienced what you were saying, even if you had someone you could refer to do that mental health work, if they're of the affirming mindset, as soon as they hear gender, they would reroute them to you anyway. And I definitely experienced that happening when I felt that a young person was psychiatrically unstable enough that I didn't feel comfortable. I didn't feel that they could possibly consent to irreversible medical treatment in their mental state. And so I referred them to a mental health facility. But as soon as they heard gender, they rerouted them back to us saying, well, we feel that if you transition them, then let's see if their mental health stabilizes then. So it's two very different ways of thinking, right?
Well, so that's the theory though, right? I mean, the theory is if we give you the medical intervention, that we'll see your mental health improve. And that also is falling apart. So it's not what's happening. So I saw our patients. I saw so many patients that we would say, okay, well then we're gonna start the blocker. And 6 months out, isn't that mental health supposed to be, if this theory holds true, isn't that mental health supposed to be improving? Okay, so what happens when we see young person after young person where they're getting worse? Where parents are calling up the nurse and saying they are falling apart, where they went from maybe needing a basic antidepressant to now being on 3 or 4 psychotropic medications, where maybe they had some suicidal thoughts and now we're having attempts, because that's also what I was seeing. And the problem with the model was that we would force you to see a therapist long enough to get a letter. But if we put you on a blocker or if we put you on testosterone and you were coming back to us, there was zero, we would never say, you know what, you have to be engaged in mental health care. We never did that. We would refer them, we would suggest it over and over again, but we would never stop the medical intervention, even if their mental health was deteriorating. And we would never say, in order for you to continue testosterone, we need you to be engaged in mental health care. We never did that either. And so I felt that I was complicit in harming these kids because we were not providing or requiring or really making sure that their mental health was supported through the entire process. There was no requirement for it. And I just started to see patient after patient who the intervention was not helping. And sometimes there were some patients that you were like, oh, okay, so they had a year or two and everything was good. But then 2, 3 years into it, now they're showing up at the center and their name has now shifted 3 times in the last month. And now they're taking on, where they are maybe originally had chosen more of a like a human name or a name that was like, I now we're coming in saying my name is like an inanimate object and now my pronouns have shifted 4 more times. And that's really concerning.
Yeah.
And then we also started seeing the patients who were developing these somatization disorders, where they were saying now that they had multiple personalities, that they were saying that they have tics, now they have Tourette's. And to me, that was indicative of continued social contagion that was still in play. So part of the assessment process that I never, ever saw was an actual understanding of it. How many hours are you actually on TikTok? Are you watching like multiple personality videos for like 6 hours straight? Like those kind of things, like it was to the point where we almost started a list for the patients with tic disorders, Tourette's, DID, because it was almost like they caught the social contagion and now they're trans identified, but that wasn't enough. Now they also have DID and now they also have Tourette's. And it was just like, what are we doing with these kids?
It does seem to happen in clusters. Yeah.
But then the clinicians would say that the DID is a social contagion, that the Tourette's is a social contagion. And I was like, whoa, maybe we should back up and ask the question, like, was the trans identification from the get-go a social contagion?
Yeah.
And you wrote that they said no because gender identity is innate, but that's immediately contradicted by the kids who come back and now they're, gender is a rock. It's like
now they're non-binary and now they've shifted and now, I mean, it was to the point where every time we had clinic, I just felt like all we were seeing was severely mentally ill, non-functioning kids. I mean, even the kids who had medicalized and you thought were doing well, sometimes I felt like the blocker and then the cross-sex hormones were kind of freezing them too in like these ages where for a while they're like none of our patients were getting a driver's license and none of our patients were really staying in school. And, we had kids going on to homebound and just the things that you would want to see young people achieving as social, like these are the markers of you getting older and progressing. We were not seeing. And it's just really hard when I think about those kids because we all thought, and so many people still think that this model is that we're making them better, that we're helping them. And I just wish that the evidence bore itself out on the other side.
It's not taking into account this social contagion phenomenon, and they're not doing us any favors by continuing to deny that is a significant problem, and potentially the majority of the kids coming to these clinics are the ones that are caught up in like a youth subculture or picking this stuff up on TikTok. I used to work for the Provincial Eating Disorders program in my province, and when I was there for 5 years, and it was before 2015, so before that spike in teenage girls adopting trans identities. I don't remember seeing a single trans patient in the program while I was there, but I still have friends in that program, and a nurse there said that now the unit is completely flooded with trans-identified young people whose identities are shifting constantly, who are changing their pronoun multiple times during their admission and then having a meltdown if the nurses get it wrong because they can't keep up and remember what their new pronouns are. And they don't know how to contain this. Like it's like this social leverage that the patients have where they can just wreak havoc on the entire program. And the nurses, because trans is this like sacred cow that no one ever wants to push back on anything trans, the nurses have no way of containing it. And so it's these behaviors that are just out of control. And I don't see how that's serving the patients well to feel that dysregulated and out of control with no limits.
And there was a very small number of times, but I did have some experiences with young people who would admit this is, I had a parent and a child who was a research study. I interviewed the youth for about an hour, then I interviewed the parent, and both the parent and the kid used the same phrase, this is punk rock.
Mm-hmm.
Mhm.
And they owned that. And this was a kid who said, you know, Jamie, like 3 months ago, I wanted tea. And they kind of had a little bit of like an awakening of their own. And they came to the conclusion, hey, I'm really into this because of X, TikTok and social media and my peer group and all that. And they had the support of their parent to be able to come out. And I really credit that for approaching this in this way where when the child first came out to the parent, they were supportive in a way that was not. There's a way to support your young person but you also don't have to buy in and go out here. That mom said, glad you're thinking about these things. You can cut your hair however you want. You can wear whatever clothes you want. We don't care. But the mom did not go into this full bore, we're going to socially transition you. The mom said, hey, you're figuring this out. Go for it. And I think it was because that mom's response to the kid gave the kid the ability to then do that experimentation, think about these things, see what was going on for them in their social group, and then have a way out the other side. What I get really worried about is the parents who, as soon as their kid says anything at all about gender exploration, or sometimes the kids come out and they're like real, like I also heard some really horrible stories as a parent that I would never want to experience. I had one parent telling me that their kid's 13th birthday was coming up, natal girl. Kid asked mom to decorate the cupcakes in pink, blue, and white icing and asked mom to line them up. Okay, so you and I both know exactly where this is going, right? Do you know where this is going? Birthday party, lining up all the cupcakes, pink, blue, and white stripes.
Yeah, I know it's a trans flag, but I don't know where this is going.
So then they sing happy birthday. All of the teens in the room start giggling, laughing, because immediately then in front of all of the extended family and all of the peers, they make this huge announcement to mom and dad. I'm trans. This is my new name. These are my new pronouns. And the peer group all starts clapping for the kid. And the parents are left in a position with the grandparents and the aunt, like, how do you even respond to that? And some parents just dive right in and go full bore, and they socially transition their kid, and they kind of give their kid no way to come out to explore, to really explore it. They go so far in that then I have heard some young people tell me that they can't even see a way back out.
Yeah.
It's really hard.
So what has this been like for you personally? I mean, it must be difficult. I mean, you entered into the work with great intentions of supporting these kids, and you're not frothing at the most transphobe. You were there to support them.
Wait,
right?
You haven't seen that on Twitter? Because according to Twitter, I am. I'm also, according to Twitter, I've lost friends. I know I have upset a lot of people. And I think part of the upsetness is because of the way that this kind of had to go down. Being a whistleblower and using whistleblower protections is a real thing, and it involves laws, and it's not something where I can like tell everybody that I know, the week before, hey, by the way, this is going to happen. I'm going to go meet with the attorney general of my state. I mean, everything had to be quiet and done correctly and through attorneys. And so I think what happened for a lot of people is they were completely caught off guard. For them, this came out of nowhere, and they thought that I mean, I've had people tell me that I have been manipulated and co-opted by the right, and that I'm being, used by, the political right, where the truth lies in a really difficult middle ground, where unfortunately, on some level, as I tried to figure out how to address this in the most ethical way, the only people that would offer me support or even represent me as attorneys are those who are in a different political affiliation. And I think that's part of the biggest misservice to medicine right now and science and even the youth, is that you cannot have any sort of real open dialogue about, is this the right medical path? Are we doing the right thing? Is the data there to support it? Are we potentially harming kids? Like, we can't even ask those questions without being completely villainized. So I definitely have had a lot of people who completely backed away and are really, really mad at me. I've also had people that I maybe knew me on the periphery, and know me from different avenues. So know me from my work with youth. I teach swimming with kids or gymnastics or like all these other things. And they reached out to me and said things like, you've worked with my kids for years. If there was anybody that was going to ethically have to stand up, we knew it was going to be you. Those have been helpful comments. One of the things that I maybe should not be surprised about, maybe you all can clue me in on this, but my state has an organization that's supposed to be the LG, the B, the T, the Q, I, A, yeah, like the queer organization in my state. I think it's super interesting because I volunteered for this organization in high school back when its name was PrEP, which was the Privacy Rights Education Project. I met one of my first girlfriends at this, like, volunteering there. Like, I was like clued in with this group for like decades ago. And it's amazing to me that that group is one of the groups that's attacking me online the most. And I'm like, what? Wait, I'm still a queer person, and I thought that don't you like represent all of us? Like, they're the ones tweeting out like, good morning to everybody except for Jamie Reed. Wow. And I'm like, okay, I don't know what has happened to the movement, as a whole, but as a queer person, I have been completely, I guess the word is disavowed, and yeah.
Yeah, you're an apostate. What's been the logic of the response? Do you know, like, so that organization, for example, they're obviously very upset with you. Are they saying that you're lying about what's happening in the gender clinic, or are they saying, or is their impression that what's happening in the gender clinic is great and you're totally out of line for pretending or saying it's a problem? Like, well, that's what I've seen a lot. I can't figure out what people's objections to your whistleblowing is, because it seems like half of it is like, oh, she's lying, that's not true, and then the other half seems to be vaguely like, what? Okay, here's another. In the WPATH SOC8 symposium, they had a presentation that was all about how do we get gender queer and non-binary kids on gender affirming medicine. So what surgeries and what hormones can we offer these non-binary and gender queer kids? That's WPATH itself. If WPATH's saying that, then what you've done is not like, it's routine. What's happening in that clinic, in your clinic, is routine. So it's like, what are these activists upset about? It's like, they should know that's the practice. That's what's going on. And yet, like, so what is it that they're upset about from your perspective?
So I think that's a really good question. So I think that it's multifaceted. So I definitely know that there is some group of people that think I am lying, that I'm completely making this all up, that I have just like, that I'm I don't know that they have claimed that. And I think part of that is some of the parents who had been through our center who would say like, well, there's no way that this is true because my child saw the therapist 39 times. And I have never claimed that every single patient that's ever been through the center only had 2 visits, but it was becoming more and more common practice. It got to the point where towards the end, there was a parent who gave us a letter where there was only 1 visit with a mental health provider. And the mom actually straight up said, I refuse to force my child to go to any more assessments or therapy. They just need these hormones. So there is some parents who feel like they did get more comprehensive care. And I think you see the same thing out of the Tavistock, though. It's kind of a Russian roulette of what provider you get at the time. And some of the providers at JIDS were doing 8, 9, 10 sessions, and some were doing 2. And so, sure, there are parents who had a very different experience. And then there are parents whose kids, I know that there are some kids that are doing well, that were blocked and then started on cross-sex hormones and are doing fantastic, that they've gone to college, that they're doing well. I think what we need to be asking is not, did this work for a few kids? I think we need to be asking real data numbers. Are we harming, like, where's the line as a society? Are we comfortable with harming 12 kids if 1 kid does well? Are we comfortable? Like, let's ask ourselves that. Like, if we really want to have these conversations, then is that parent saying that it's okay that we know we harmed 12 other kids, probably going to desist and detransition in a decade, probably are going to be left with vocal cords that are, not in the pitch that they feel comfortable with, left with, a microphallus, left with vaginal atrophy. I mean, like, so let's actually have that conversation. Do you think it's okay that 12 kids got hurt and 1 did well? Because if that's the case, then maybe that's how we all want to agree to this treatment. But I think there's another way where we could ask, is there a way that we slow down enough that those 12 kids never got put on cross-sex hormones to begin with? And we really did the work and figure out the science and go back to the Dutch model and look at what we could maybe do differently to know that the 1 kid that might benefit, that we've figured this out all the way so we can identify the 1 kid and make sure that's the only kid that we're pushing through. Mm-hmm. I don't know why we can't actually have that conversation. And then the other point is that I think there are a lot of people that are seeing what's happening in the state legislatures in my country. And it becomes these bills that are kind of all or nothing. And on some level, I feel really stuck about the legislation, because if we could trust that the American Academy of Pediatrics, and if anybody who ever listens to me has any way to talk to them, this is the year where they're, okay, so let me take 2 steps back. So the American Academy in 2018 put out a policy statement by Jason Rafferty. It was not a standard of care. It was their policy statement. That is expiring this year. So all of these court cases, all of this, it's all on some level, this year is this going to have to be figured out. So the American Academy of Pediatrics, in my opinion, all of this legislative nonsense doesn't even have to be on the table if they would step up and do their job, which is to actually review the data. So we live in a country where I think we have the technology, we have the medical charts, we have the way that the American Academy of Pediatrics could say to every single pediatric gender clinic in this country, hey, you have 6 months. We need your data. We need to know how many kids have been through your system, what are their ages, what are their natal sexes, what did you do to them? It's It's simple. How many kids? And then what did you do to them? What age did you do it to them? Did you put them on blockers? Did you put them on cross-sex hormones? And then and we all need to agree, what were some of the outcomes? So if it's that we have a PHQ-9 or GAD-7, so a basic depression or anxiety screener, what do their labs look like? Did their cholesterol suddenly go to shit? Are they now needing, like all of these other interventions? Do they have sleep apnea now? Do they have all these other problems? Like, what were the outcomes of your intervention? And the American Academy can say, we need all your data. They collect it all, and then they can publish it online so we can see what is actually happening. So this is not a brand new concept. I now work in bone marrow transplants. And there is a nationally collected data set. It shows how many bone marrow transplants did this children's hospital do last year and what was the outcome. And for parents who need a bone marrow transplant for their kids, they can go to that data and they could see, did it work? How many kids are still alive? How many kids' cancer is doing better? So we can do this, and the American Academy of Pediatrics can do this. And then 6 months from now, after they collect all the data, then we can look at it collectively as a community, as a medical establishment, and we can decide, is this working or is it not? And then the American Academy of Pediatrics can change their policy and put out an actual standard of care that is not just one random guy, sorry, Jason Rafferty, who decided to write some position paper.
Yeah. And there are pediatricians within the APA who have been pushing for them to do a systematic review of the evidence, and the APA has been outright refusing. And that you can't call any type of care evidence-based until a systematic review of evidence has been done. And why they would refuse to do that is bizarre to me.
I don't know. Did you read the Endocrine Society guidelines? Because when they actually did it, it was all low quality evidence.
Yeah.
So the evidence is just not holding water right now, but that doesn't mean we have to throw out the entire model of care. I think it just means that we need to stop, pause with kids, look at the data, look at what's happening, and figure out a good way to do that. And there are also ways that universities and hospitals, like where I work, we already have institutional ways to run research studies. We know how to oversight. We know how to do oversight for research studies. I don't understand. I have no comprehension of how this jumped from the Dutch into the US and was never put under IRB approval or review. How is it that we were doing this care with kids and there was not an institutional review board who were making sure that this was set up with tight controls, with tight informed consent, with also actual parameters for harm. So if we put you on something and it harmed you, then we're going to stop the intervention and then take care of the harm that we caused you.
Yeah. And in fairness to the Dutch, I mean, the model that's being practiced these days is a departure from what the Dutch were doing as well. I mean, I think it was Laura Edwards-Leeper that brought the Dutch model to the US, but she's very much an advocate for let's take our time to do really thorough assessments and an exploratory approach. But she's been demonized as well for trying to maintain those guardrails around the system. And she's on her way to being bullied out of the system along with every other clinician that believes in guardrails and safekeeping.
Okay, but we still are talking about kids. This is the thing that I don't get. We still are talking about kids. And those are the conversations that happened in the center sometimes where I worked at, where there would be this pressure and push from the adult community, and the employees would kind of be responsive to that. And I kept trying to remind people, we are still talking about children, and we safeguard childhood in a different way than we safeguard adult choices. There are reasons why adults can go get whatever crappy tattoos they want and be stuck with them for the rest of their life. There are reasons why we safeguard some of those practices. And I think you had Alice Draper on,
Drager,
Drager on your show. And I remember listening to her and I was like yelling at myself through the headphones while I was gardening because she was saying things like, well, adolescents get to make all sorts of terrible choices. They can have unprotected sex and they can go get a tattoo and they can do X, Y, and Z. And I kept going, no, in this country, you cannot get a tattoo when you're 13. And we're putting 13-year-olds on testosterone. And no, actually, you are not really technically allowed to consent for, yes, the other things that she was talking about, like as a young child, like, come on, like, no, we're still talking about kids.
Yeah, that was pretty frustrating. I think to Alice's defense a little bit is I think she basically, right after publishing Galileo's Middle Finger around 2015, I think she's been well out of the gender loop. So I don't think she understands the mass of what's happening right now, the gravity of it all. That's the only thing that I could rationalize why she's taking that stance. But it definitely surprised me. And I was
and
surprisingly disappointed with that.
I loved the book.
Yeah, it's great. Good.
I really did. And, honestly, on some level, in retrospect,
that's why I'm so surprised at her take.
I'm like,
right?
Can you, hey, Alice, come help us out. Because me and Laura and Erica, like, we're getting like completely like blasted, for doing what you were talking about. Science should. Yes. You get it. Yeah.
Yep. I'm curious though, what kind of, so at least in your clinic, when you're saying that the APA should do this review that includes, what the outcome is, obviously that should be the most important piece, is like, were these people helped or harmed, in what ways? But like you were saying, is that the director or whomever was basically saying, oh, if somebody detransitions, they're no longer our patient, so we don't worry about that. Like, how is the outcome? How are outcomes actually being monitored if they are?
Okay, so I do want to answer that question, but I want to jump in on one little thing you started to say. So I don't think that the AAP just needs to do something like this only purely for outcomes, because part of what we actually do not know, and part of what I found so frustrating sometimes with the way that my clinic was being represented to our state legislature, was there are some outright falsehoods being stated. So in my own state, they would go to the legislature and say, there's no surgery happening with minors. And they would say that. And yet I would be in clinic and know that they just looked at how somebody's top surgery scars are healing who is 16 or 17. Did it happen a lot? No. And part of my own complicity, I assisted parents trying to get insurance coverage for top surgery for their minors and tried to explain different ways for them to get around their insurance to get their minors covered. So part of what I do still think part of what we actually need to start talking about honestly is what is actually happening. And what is actually happening is, yes, there are minors having surgery in this country, and the age that people were starting testosterone in our center was not 16 as the standard said, it was 13. And that was even back when we were under SOC 7. And SOC 7 even said that if you were under the age of 16, there should be a compelling and special reason why we would start testosterone under the age of 16. And I would ask, what is the compelling reason in this case? And it was over and over again, 13 and a half, 13, we were just starting T. And so part of what we do actually have to know in our society to actually have this dialogue is to actually know what's happening. And the only way we're going to do that is we really get data out of these clinics. The second part of your question, when we got our first patient who notified us that they were detransitioning, I was under the false assumption that we would do a systematic stop, pause. We're going to really review this patient's chart. We're going to look at exactly what happened. We are going to figure out what in essence went wrong with this case. I thought we would want to talk to the therapist who wrote the letter. I thought we would want to do this in a really systematic way. And that was not the case. That was not what was wanted from my providers. And there was, on some level, like this kind of like, well, what else? We don't have anything else to do for them. Like, if I'm not, think about it from an endocrinologist standpoint. If I'm not prescribing them hormones, why do I need to see them? I only see these people because I give them hormones. And so they kind of had like a, no, I don't need to see the detransitioning kids. And I know that there are way more detransitioning kids that never told us that they were detransitioning. We would only find out about it sometimes even on accident, when the nurse would maybe call and check in with a parent and say, hey, I noticed that this prescription hasn't been picked up in 3 months, or you haven't been back in 6 months. Did we need to send more things in? And every once in a while, then we'd find out from a parent, oh, they stopped. They're not doing that anymore. I still think, and I remember one of those kind of important moments in my own path and kind of journey out of the clinic on the other side was when the 60 Minutes episode aired with the detransitioners. And I just felt so much that they have so much to teach us. And if we really do want to figure out a way to make this a model of care that could work, the only way to really do this is to learn from them and to hear them and to learn in a scientific way what were the elements that should have indicated to the clinicians that they should not have been put forward to medicalization.
Yeah, it's going to take a lot more than 2 visits to have figured that out.
It also, I think, needs to be willing to acknowledge the harm. I almost feel like we've painted some detransitioners into a box where, it's now being called, like, oh, it's retransition, or we're changing all the language around it, or we're kind of making it so that I think we have to be able to acknowledge. I do feel like a lot of people have been harmed. I do think it's a harm that your voice has been changed forever. If that's not the way you want your voice to be, I think it's a harm. I think about those kids who are now like maybe in their 20s and how they feel now. And I really wonder how that's going to play out in 20, 30 years. Like, bodies change so much over time. And especially maybe some of the kids who have had these irreversible things done to them. Like, how is that going to feel if you're in a relationship in 10 years and you maybe want to have a child, a biological child, and you want to breastfeed your biological child, and we've changed these things. I think it's disingenuous to not allow there to be the feeling of mourning and harm and pain. And then the flip side of that is also that as a medical establishment, I think we have to be willing to acknowledge that that might deserve some court cases, that might deserve some ways to rectify that pain for those people.
Well said.
Absolutely.
Well, I want to be sensitive to your time. I really have loved this conversation. I've loved meeting you, and thank you so much for agreeing to come in on our humble little show here and talk to us.
Oh, I just want you to both know that part of my pathway to becoming a whistleblower is actually because of you. I found, I think, Stella and Sasha first and their show, and started listening to them. And then I found your show, and there was something really powerful to me about hearing from two adult trans individuals in our queer community who were willing to take that moment to be open to having the dialogue. And it was because of hearing some of your shows that gave me some of that feeling of safety and hope and knowledge that maybe I could move forward and maybe I could bring some light to this. So you were instrumental in part to that. So I really appreciate you both for that.
That means a lot.
Yeah, it does mean a lot to us. And we really appreciate that you have stepped forward as a whistleblower to protect these kids. So thank you so much for your contribution. And even if you move on with your life and never think about this stuff again, you've done your part, right, to protect them. And so thank you on behalf of so many parents that reach out to us afraid for their kids.
Thank you for that.
Thank you.
Thanks for joining us for this episode of the Transparency Podcast. If you enjoy our content, please help out our algorithm by hitting like or subscribe. If you'd like to make a donation, follow the link to our PayPal account. On behalf of the Gender Dysphoria Alliance, thanks for your support.